Bismillah ar-Rahman ar-Rahim. We are going in this second part of our lecture to tackle physiology of the thyroid gland and investigations. As we can all know that the thyroid gland is an endocrine gland, so it is under the control of the anterior pituitary gland within a very simple endocrine feedback axis. As we can see, the hypothalamus produces the thyroid releasing hormone, which acts on the anterior pituitary to release the thyroid stimulating hormone, or TSH, that acts on the thyroid gland so that it secretes T3 and T4, both reaching different organs of the body through the bloodstream and being in the blood, they form a negative feedback inhibition or stimulation on the pituitary and the hypothalamus gland. To have a very simple idea that our diet containing iodine or iodide is absorbed in the gut, reaches the blood, trapped by the thyroid gland through iodine trapping enzyme and changed into iodine, which then is organified by the organic binding enzyme with tyrosine, the enzyme tyrosinase, together with tyrosine, the amino acid, the famous amino acid, to form two structures, monoiodotyrosine and diiodotyrosine. Then, through the coupling enzyme, one of the monoiodo and another similar one of the monoiodo forms what is known as T2, and this has no metabolic pathway. This has no metabolic pathway, so it disintegrates again into its components. And the coupling enzyme also couples a mono with a diiodo, forming the T3, and two iodo to form the T4. These are the two hormones through which the thyroid gland controls the metabolism and functions of the different body organs. However, these T3 and T4 enzyme hormones are bind with a globulin inside the follicles, form what is known as the thyroglobulin, or colloid in the pathology language. When the body needs it, a protease enzyme acts on this thyroglobulin through a process known as proteolysis to disintegrate the protein part remaining inside the gland, and the T3 and T4 becoming free goes into the blood. Whenever they go into the blood, again, they are taken within the plasma proteins, to form a bound form of the hormone. This represents between 99 and 99.5% of the thyroid hormones, leaving 0.5 to 1% of the total amount as a free part, and this is the acting part that makes us merrily alive. So we have to know that these different steps might be hindered or blocked or delayed by some chemicals that are present in some foods, and of course in the anti-thyroid drugs, so that when the gland is producing larger amounts of hormones than those needed by the body, man can go into this cycle to break it by these anti-thyroid drugs. However, we have to know that as well as the iodine being the raw material through which this gland forms its hormones, also the iodine, but in large amounts, can hinder the output through blocking this last step of proteolysis. Not only the iodine, but also the lithium. What's the importance of lithium to be mentioned here is that the lithium is an important, if not constant, agent in the mood stabilizing agents and many antipsychotic agents. And that's why it's very important to know that any drug, any other drug containing iodine or lithium might hinder the proteolysis, might block it, decreasing the T3 and T4 being released into the blood, elevating the TSH, which results into a goiter, an enlarged thyroid gland. And in such a case, of course, the tackle should be to prevent this vicious circle, not to remove the thyroid gland. The difference between the free T3 and free T4, I'm happy to leave you with this table that forms a very important, that shows the different the different aspects of each one of them. Going into the last section of our lecture, this is the section of investigations. First, we have to start with the lab concerning the thyroid gland, and these are the thyroid function tests. These include the TSH, the thyroid stimulating hormone, the free portion of T3, the free portion of T4. And why do we measure the free parts? Because as you can see here, assays of total hormones for both are now obsolete because of the confounding effect of circulating protein concentrations influenced by the level of the circulating estrogen and nutritional state. And this is a quote I'm happy to take from a general surgery textbook, which is the esteemed Bailey and Love. All rights are preserved for the authors because this is a textbook of general surgery, not a head and neck or endocrine specialized textbook. And still, we have to find this very important advice from their authors because it is not informative if we ask the patient to have T3 and T4 to use it to estimate his state of thyroid activity. Likewise, from the same textbook, Bailey and Love's Short Practice of Surgery, we can find here a very useful, simple table to tell us that if the patient is euthyroid, then he will have a normal TSH, normal free T4, and normal free T3. If he is thyrotoxic, he will have an undetectable TSH, high T3, free T3 and free T4. If he's myxedematous or hypothyroid, sorry for that, he will have a high TSH and low free T3 and free T4. If he is under a suppressive T4 therapy, the TSH will be undetectable and still the free T4 is high and free T3 might be high or might be normal. The T3 toxicity, which is a rare disease, we have a low or undetectable TSH with a normal free T4 and high free T3. So there is TSH, FT3, and FT4, and still we have the antibodies. The anti-thyroglobulin and anti-peroxidase antibodies, where these antibodies were formerly described as markers for Hashimoto thyroiditis. They do not increase except in Hashimoto thyroiditis. However, modern medicine teaches us all that these antibodies are elevated in merely all diseases of the thyroid gland, but they are shooting in Hashimoto thyroiditis, making the diagnosis much easier. Also, we have the new or recent TSH receptor antibodies or TREP antibodies, which are specifically high in Graves' disease. As regards the anti-thyroglobulin and anti-peroxidase antibodies, these are important levels. These are important antibodies where levels above 25 units antibody and titers of greater than 1 to 100 are considered significant. Although, on the contrary, a portion of patients with histological evidence of lymphocytic autoimmune Hashimoto thyroiditis are seronegative. So they might be shooting, but sometimes they are negative in a seronegative Hashimoto patient. This is very important. Second part of investigations is imaging. Imaging we might ask for a plain X-ray of the neck and chest, barium swallow, ultrasound neck, CT neck, MRI neck, or any other form of imaging, tailored to each patient. However, the one and the only imaging tool that we can never skip in a patient of a thyroid disease is the ultrasound. The ultrasound is a constant piece of imaging that we have to ask for always. On the contrary to radioisotope studies, which include either radioactive iodine uptake, T3 suppression test, or T3 resin uptake test, which are of historical importance, but thyroid scanning has a role, but a limited role, in the diagnosis of thyroid diseases, in which we either use iodine 131, iodine 123, or technetium 99 with the differences depicted in the table. Usually, we use iodine 123 for diagnosis, or more commonly, the 99 technetium, and iodine 131 is reserved for therapy. This is how a thyroid scan might appear, where the thyroid gland is drawn by a gamma camera, however, with a part not taking the radioactive material, termed as a cold nodule. Here, the whole gland has taken the tracer equally. Here again, there is a cold nodule in the lower and middle part of the left lobe. This cold nodule was formerly said to be a malignant nodule. Now it is much less than 10% for a cold nodule to be malignant. And so the accuracy of a radioactive iodine scan or a technetium scan to diagnose or share in the diagnosis of thyroid malignancies is very questionable now. Number 4 is a biopsy. The fine needle aspiration biopsy is a very important part of investigations. It is described in the American Thyroid Association Guidelines 2016, the last one issued, to be the single most important diagnostic tool for diagnosing and assessing thyroid nodules. True cut needle biopsy has a role in diagnosis in limited and selected patients and under certain experienced hands, because it might carry more risk than the fine needle. Laryngoscopy, either direct or indirect, is very important to assess the mobility of the vocal folds for the proximity of the thyroid gland to the recurrent laryngeal nerves, affecting or controlling the mobility of the folds. So, the routine investigations that we all do for merely all thyroid patients are TSH, FT3 and FT4, thyroid autoantibodies, ultrasound, and fine needle aspiration cytology if advised by the sonograph, because in one day the fine needle was taken by the clinician or by the pathologist. Now the interventional radiologist, the one who is doing the ultrasound, should be the one taking the decision whether to have a fine needle or not, according, of course, to the TIRAD classification of the thyroid nodules, which is a bit recent classification. Any other investigation than these should be tailored according to each case. So this concludes our second part of thyroid introduction, in which we had a simple idea about thyroid physiology and investigations needed for a thyroid case. I'm happy to receive any questions or any demands about my lecture or my any other lectures through this email. Thank you for your attention and have a good time. Assalamu alaikum wa rahmatullahi wa barakatuh.